Good morning, everyone. And I'm going to not just give you an update. I just wonder whether the RUSP is ethical. Um, uh, as you all know, Krabbe disease was added last year. It was in a limited fashion. And so we'll first kind of go back in time a little bit, and then we'll move into the question whether what happened is good. So going back in times, more than 100 years ago, Knut Krabbe described this condition, which we now know as Krabbe disease. What he described was the classic form of Krabbe disease. What we now know is infantile Krabbe disease, where these patients present in the first few months, starting with severe irritability, and then have a rapidly progressive neurological phenotype that ends with death, usually at less than 2 years old. However, over time, we learned that there are milder variants. There's late infantile Krabbe disease, as we now know it, where the onset is between 1 and 3 years old. It is also progressive. It's also lethal. These patients typically die within 7 years. And then there's juvenile, as the name suggested, presents a little later. The naming is always a little funny. You call it juvenile, but onset is as between 4 and 17 years. And then there's adult onset Krabbe disease, which is has also, from a phenotype perspective, milder symptoms, fairly non-specific. So it's hard to identify these patients. They go through a diagnostic odyssey until someone eventually figures out, well, this could be Krabbe disease, and they order a specific test, or nowadays they get some form of exome or genome, and then someone finds a genotype that is suggestive of being possibly Krabbe disease. There are some treatment options. Those patients that are identified because they have symptoms are usually being treated symptomatically. That means they get comfort and help to make their life easier. If you're identified early enough, Joan Kurtzberg and Maria Escola showed 20 years ago that if you do a bone marrow transplant, then these patients have a much better prognosis. They did a comparison between patients that were transplanted before they had onset of symptoms to their older siblings who were diagnosed clinically, and could really nicely show that there is a significant difference, in particular in longevity, but also overall in quality of life. Otherwise, there's nothing else you can do. There's currently no real clinical trial. There are patients that were entered into 2 different clinical trials. Those patients are being followed, but for business decisions, these trials have ended. So we have to hope that someone else will come in and save the day or save these children to give them even better outcomes than the transplant. However, as I kind of alluded to, if you don't identify these patients early enough, it really is just a symptomatic treatment, and you make them comfortable. And patients that have a negative family history will not be identified early enough to really benefit. So this, of course, then brought up the idea of newborn screening. And New York was the first state to start after Mike Gelb, who I haven't seen yet, developed a tandem MS-based assay to measure GALC activity. And that allowed then Dr. Orsini to start newborn screening for Krabbe disease in 2006. So, and that was, of course, with significant advocacy effort from the Hunter's Hope Foundation. And today you have 13 states screening for Krabbe disease. That means that more than 1/3 of US babies are currently being screened for Krabbe disease. So took a long time, but this is where we are now. Maryland was the most recent state to start screening. In this year, we might see more states starting to screen, which would bring us another 12% up when it comes to the annual birth rate. So you have almost half of the US babies that might be screened for Krabbe disease by the end of the year. If you consider that Krabbe disease was only added to the RUSP last year, this might be the fastest implementation if you pretend that it didn't start in 2006. Um, so you just have to spin it right. Um, then in the coming year, you might see additional states coming on, in particular California, which has the highest birth rate of about 400,000 babies a year. So that will make a significant dent. And I just heard that Wisconsin might start early next year as well. So things will happen, and there are probably other states that are thinking about it. The other thing is that some of these states are providing screening for additional states. When Iowa starts newborn screening for Krabbe disease, the Dakotas and Alaska could immediately start as well because they have the newborn screening done through Iowa. And Mexico has a screening done through Oregon. So when they start screening, then New Mexico could basically sign on and have their baby screened as well. If Massachusetts decided to screen for Krabbe disease, then all of the New England states would be able to get screened their babies as well. So I think we're going to see rapid progression as much as one can foresee that these days. Now, one of the problems with Krabbe disease has been that initially all you had was basically the GALC activity, and then you had molecular genetic testing as a second-tier test, which New York implemented. And the impression was that, well, all of these patients really have primarily a common deletion. So the genotyping will quickly figure out whether this patient has Krabbe disease because they not only have low GALC activity, but they also have a pathogenic genotype. So it should be easy. But of course, once you start screening, you realize, well, there are many variants that we've never seen before. And so there were a lot of genotypes of uncertain significance. And that really rubbed a lot of people the wrong way, in particular on the advisory committee. So then Psychosine came around, and that allowed to make screening a little better because now with Psychosine, you had a biomarker that is pretty specific for Krabbe disease. So if it's elevated, you basically have knowledge that this patient does have Krabbe disease. It is important that you have as few false positives as possible because it's a terrible disease, and I don't think it's a good idea to tell too many people that their baby may have Krabbe disease. Then they might Google it, and then they get anxious. But tell them, well, we just do the test again, and then it all goes away. That's not the best way, and it doesn't really work so well. Also, once you say it could be Krabbe disease, you have to consider that a bone marrow transplant is supposed to happen before the 30th day of life, if possible, no later than 45 days. So they have a time crunch to do a lot of investigations to determine whether the baby is actually affected and has the infantile form of Krabbe disease. So that is pretty costly and invasive, and few centers that can do this very quickly. So that's another reason why it's important to have no false positives. But again, there were several ways of doing it. So one is to do GALC activity and do Psychosine. The other one is to do Psychosine and GALC sequencing. And if you do those in parallel, then you might find a patient with low GALC activity, normal Psychosine, but a genotype that you don't know exactly what it means, so you still report it out and you really don't save a lot of false positives. Or you rely on Psychosine, but because you might send it to a different lab, so you have a little bit of a delay, you might say, well, GALC activity is really low. I'm just going to tell the clinicians that we have this and you deal with it, and we'll tell you in a couple of days whether Psychosine is elevated or not. And that also creates havoc because what are you going to do when someone tells you, well, it's really low GALC activity, so it could be that the patient has Krabbe disease. So again, I don't think the best way of doing it. And there are states that don't use any second-tier test, where then you will have a lot of false positives because, again, there's a significant overlap between GALC activity in patients with Krabbe disease and then these patients with pseudodeficiency, where you have a genotype that confers lower activity but doesn't make you sick. So these are some problems. With the help of many of you here in the room, we looked at this, trying to help the advisory committee to understand the impact of the various screening strategies. And so we did a survey of several states, and looked at what the situation was. If you look at the states, and we were looking only at those that were using cyclozine, and one of the things we noted is there are different cutoffs used for cyclozine. If you look at Illinois in particular, they started off with a cutoff of 1.08 and then moved it to 1.5, which reduced the false positive rate tenfold. So quite a significant difference. Other states that use a cutoff of 2 has basically no false positives. And then the other question is, well, do you identify all the patients you want to identify? So false positives are very important and can be reduced. The positive predictive value accordingly goes up when you have fewer false positives. And that what we did then, we basically asked, well, what would happen in all of these states if they used only cyclozine and applied different cutoffs? So if you apply a cutoff of 10, which we kind of knew from reviews of patients that were identified through newborn screening or that were identified clinically, but we could go back at the original newborn screening card and look what the cyclozine value was. We kind of found that the lowest one with infantile Krabbe disease had a cyclozine value of 11. So we said, well, let's look at a cutoff of 10, what would happen? And indeed, all of the states that identified a patient with infantile Krabbe disease those patients had cyclozine greater than 10. Now, if you decide, well, let's try 5, what happens then? Well, you still find, of course, all the infantile cases, but now you also find a few late infantile cases, and then some that are considered late infantile Krabbe disease, where they're still asymptomatic or were at the time we wrote this. And so you don't know whether they will develop juvenile or adult onset Krabbe disease. So there's still some uncertainty that you introduce with a cutoff of 5. If you reduce it to 2, you identified, of course, all the ones you want to identify. You identify more late infantile cases, and you identify more of these late onset where we don't know exactly whether they're going to develop symptoms. However, they do have a biochemical phenotype. So in my thinking, at some point they will have symptoms of Krabbe disease. Now, the advisory committee that reviewed Krabbe 3 times, and this paper came out just a few days before their last meeting. I don't think they read it, but anyway, so they decided, well, we really don't want any false positives, and we really want you guys to go away from us and not come back ever. And so they decided, we'll say, okay, we'll say that cyclozine should be used. A cutoff of 10 should be applied. And then you have as core condition Krabbe disease. That was the last slide of the liaisons between the evidence review group and the advisory committee that put out the slide that infantile Krabbe disease should be the core condition with low GALC activity and high cyclozine, which is what the proponents kind of said. Well, you can go with infantile Krabbe disease as a core condition, and the RUSP has another category for secondary targets, which are basically the differential diagnosis of the conditions that you identify when you screen for the primary target. So if you screen for PKU or phenylketonuria, you use phenylalanine, which will identify the patient with PKU, but it also will identify patients with other disorders that go along with high phenylalanine. So those are secondary targets. So the idea was here that, okay, you'd use infantile Krabbe disease as a core condition, and then the later onset forms as the secondary targets. So this is a letter from the HHS secretary at the time last year back to the committee and saying, yep, I agree with you. Infantile Krabbe disease with low GALC activity and cyclozine greater than 10 should be added to the RUSP. And so it was added to the RUSP as such. No mention of core condition, but that's not unusual if you go back. Actually, the RUSP has not had any addition of a secondary target for a long time. So when adrenoleukodystrophy was added, I was actually part of the committee, and I was expecting that we will add peroxisomal biogenesis disorders as secondary targets. And you can go back, maybe if it's still online, to the meetings, and you will hear me asking every time, why is why are peroxisomal biogenesis disorders not added yet as a secondary target? And I got non-committal answers. So it's not unusual that late infantile Krabbe disease and all the other later onset forms are not added to the RUSP in writing. The question is now, what does it mean for the states? So if what the ACMG did, and I'm biased here because I'm part of the ACT Sheet working group, we created ACT Sheets for both scenarios, for infantile Krabbe disease and for the later onset forms. Not because we thought of primary and secondary targets, but because we wanted to ensure that the patient with high cyclosine have an immediate action happening immediately when you find this, versus the later onset forms where you don't have to call an emergency to get the patient in and get moving. There's also a follow-up algorithm so that you can quickly come to a diagnosis. And then Amy Gaviglio created a very nice knowledge nugget that gives you with stick figures all the necessary information you need quickly about Krabbe disease. So what are now the consequences of the RUSP recommendation? And it's a recommendation. It is not that the federal government can tell the states what to do, kind of. When it comes to the RUSP, they can't. And the states that already screened can basically continue as they have, or they can add cyclosine if they didn't have it, and they can apply any cutoff they want to. And they can add molecular or remove it. States not yet screening should take a hard look at the data and then decide what they want to do. Do they really want to follow the RUSP to the T, or do they want to use cyclosine and use a lower cutoff and find these other cases as well? So they can do what they want, or can they? So some states, 13, have state laws that they put in place to ensure that the state program screens for at least the RUSP condition. And apparently these laws could be very strict that say you do exactly what the RUSP says and nothing else, or it says do as much as you can for the RUSP, but may not necessarily say you can't do more and you can't do less. So I hope that I may leave this meeting with a better understanding of what can be done and what can't be done, but I also will tell you what I think should be done. So if we look at late infantile Krabbe disease, again, I mentioned it already, the onset is a little later than infantile Krabbe disease. These patients still will die if they're not treated, and that, I think, is something to consider. Between 2010 and the end of last year, we are through our laboratory where we do diagnostic testing with GALC activity and cyclosine and so on. We came across 9 cases that were diagnosed as late infantile Krabbe disease because they had developed symptoms. And so some of them were early enough, 4 of them, that they received a transplant. And they are, 3 of the 4 are alive. 1 had passed away because of transplant complications, which of course is always a concern. And the other ones are dead or dying. So that's late infantile Krabbe disease identified clinically. And then we know of another 8 cases that were picked up either because there was a positive family history, so they were diagnosed early and they were transplanted, and they were picked up because of newborn screening and they were transplanted. And these patients are alive and, what I'm told, well. We'll write this up, so we'll provide a little bit more insight about what well means. But from what I understand, they do well and they do better than patients with infantile Krabbe disease that get an early transplant. So maybe the late infantile cases actually benefit more from an early identification and treatment than the infantile cases. So again, we have a clear difference here. Now, we were asked, because we offer cyclosine and we do it for a few states, and some of the states said, well, we have RUSP alignment, and so we have to screen for Krabbe with cyclosine greater 10. Can you do that? And we said, well, we can maybe. I said, how about we report those back and say when it's greater than 10, well, it's infantile Krabbe disease. And when it's between less than 2, we call it normal. And when it's between 2 and 10, we say the result is not consistent with infantile Krabbe disease. And then leaving it to the states and the providers who might see the report wondering, what does that mean? Does it mean it's normal? Or does it mean it's not infantile? What's in between? And then I thought, okay, I'm done. I've done my ethical thing. I kind of told you. So, but we decided, well, let's ask the ethicists. And we have an ethics committee at Mayo. And so we asked them, what should we do? And so we went there and we sat down for an hour and we discussed it, Dr. Hall and I, with that group of 10 people, at least 10, there were probably more online, and gave them the scenario. And they got back to us with this memo where they made their recommendations, and they did not agree with me. They did not think that my report would be good. They said, you cannot just be so gray about it. You have to be more specific. And late infantile Krabbe disease, the way that we understand it, can be treated. So you cannot just say it's normal. So I don't think we will report anything between 2 and 10 as normal or not infantile. We will say this could be late infantile Krabbe disease or a later onset form of Krabbe disease. Now, we might lose business because of it, because I don't know if the states that are RUSP aligned will then just say, well, we'll find another lab that will give us what we want. But this is where we are, and where we'll have continued discussion, and maybe you will have some pointers for me as to what we should be doing. So in conclusion, the RUSP has now infantile Krabbe disease on it with a specific definition. And that, of course, will prevent all false positives. So that's great. No doubt about that. We don't want false positives. We, as proponents, suggested that infantile Krabbe disease should be the core condition and the others should be secondary conditions, but that was basically ignored. Now, the other thing, since April, there is no advisory committee anymore on the federal level. It's gone because no one needs it. All the other federal advisory committees are gone too. So nobody knows. The Secretary of Health and Human Services was in Congress at a committee and was asked about newborn screening and how MLD and conditions are being added now to the RUSP. And he, I guess, gave a wishy-washy answer and said, oh, we'll deal with it within HRSA. Well, at the same time, HRSA is supposed to go away too. So he has no clue. Or if he does, we don't know what it is. So there's a lot of uncertainty about this. The only good news is that there has been a newborn screening saves life reauthorization act coming back and forth to Congress for the last 6 years. And now it's been back, I guess, either last week or this week. So there's a committee that's going to talk about newborn screening with maybe a little bit more detail. I'm sure they have other things to talk about. So who knows what's going to go on there. And then again, as I said earlier, states that are screening for Krabbe disease really should look at their outcomes and determine how they want to go forward in light of the RUSP and maybe the disappearance of the RUSP as well. Who knows? And really look at the idea of whether it should be limited to only infantile Krabbe disease. And then the states that have RUSP alignment legislation, especially the one that is really tight, where they cannot do or go kind of deviate at all, they really have to think about whether they want to change that law. I mean, the good thing is that in theory, you can change laws through a legal process. So my call to action is that the clinicians and families who care about Krabbe disease and know something about it and would think that late infantile Krabbe disease is worthwhile screening for, find their legislators in state and talk to them about it and make them aware that the advisory committee kind of added half-heartedly Krabbe disease to the RUSP and could have done a better job. And also, what about the next condition? If MLD doesn't get on the RUSP, how will the state implement it if you have RUSP alignment? So it's not just about Krabbe disease. I think the RUSP alignment laws need to be considered in every state that has one And I think the legislators will not think about it unless you tell them about it. Also important is what I always hear from colleagues in public health laboratories, that they cannot really do this from within because they're employees of the state and they cannot be politically active, all these kind of things. So you have to go where there is a law, you have to go to the lawmakers. And with that, I'd like to acknowledge all the people who provided the data for these cases with late infantile Krabbe disease, and everyone in our lab at the Mayo who create all the data that I can tell you about. And the call to action was mine. I'm not going to throw everyone else on the slide here on the bus, under the bus, but I hope that most of you agree with me. Thank you.